Good afternoon. I'm Hannah Fontana, the Programme Manager for the Health Foundation's Increasing Continuity of Care in General Practice programme, and I'm delighted to welcome you to our first Insight webinar for the programme, and I'm really looking forward to today's discussions on continuity of care. In 2018, colleagues from the Health Foundation published an article in the BMJ which demonstrated that patients with ambulatory care sensitive conditions who see the same GP a greater proportion of the time had fewer unplanned hospital admissions. On the back of these findings, we wanted to explore whether we could support teams to use improvement methods to try and increase continuity of care for their patients and assess the impact both on patients and their workforce. In January of this year, we awarded 5 large-scale GP practices from across the UK with grants of over £250,000 over 12 to 24 months to carry out targeted quality improvement work to increase continuity in their practices. We're nearly a year into the programme, and today we will have an opportunity to hear from some of our award holders on their experiences of the work so far. We've been working closely with RCGP, our support partner for the programme, to draw out learning and insights from the programme and to share what we are finding with our community of practice and the wider audience of people who are interested in continuity of care. So thank you very much for joining the webinar this lunchtime, and I hope you enjoy the session.
And thank you to Hannah and to the Health Foundation for funding this and leading on continuity of care. Now, I'm Mark Rickenbach. I'm a Professor of Healthcare at Winchester University, and I'm a general practitioner at Park and St Francis Surgery, which is near Southampton, Chandler's Ford. And I'm also a Director of Primary Care Networks, which may be relevant. And what I want to do first of all is thank everybody for coming today. Thank you very much indeed for the team and the whole programme that's here. And there's 3 sections to this webinar. There's going to be the first section, welcome to Denis, and the first section will look at how important continuity of care is, the evidence base that's there. And the second section will look at how we can implement or put into place continuity of care. And the third section will look at getting the feedback and on how it's going and then measuring it. These sessions will be available all together, or you can look at 20-minute portions of them because they each break into a separate session. And we hope that they'll be put together as a report at the end of the programme in a year's time. Do go to the RCGP website where you will find there's a toolkit which will help you look at continuity of care in your practice. And we'll be developing that as the year goes on with additional resources added to it. And also on the website for the RCGP is a community. It's a base camp community, and you can join that and hear about continuity and see live chat about that and catch up on the news for the programme. We've got 2 of our project sites here today, the Exeter team and the South Cumbria team. And next webinar, which is December next year, we'll be having Valentine from London, we'll be having One Care from the Bristol area and Peer Health from the Bristol area as well. And so do put that in your diaries for next time. The College of GPs, Royal College of GPs, is to support the Health Foundation, and our aim is to facilitate work at the sites, to collate information that's coming out from the results, and to raise awareness of continuity of care. So for our first session, we're going to be talking to Sir Denis. Now, Sir Denis, you're a Professor of Healthcare, and you're based down at St Leonard's practice, where I think you've been for quite a while, your career there. And you've done a lot of research on continuity of care, so that's been really helpful. What I'll do is just move the slides down for you. Do that. Okay. And we'll just do there. That's great. Okay. The other thing about it, I noted, is you're an embodiment of continuity because, to a large extent, you've been 3 generations in general practice. And out of those, you were the 3rd generation, and I think you were actually born above your consulting room for your father. So well done on that. On the basis of that, what I'd like to ask is about continuity and what's the evidence base for continuity and the reason for it?
Well, thank you very much, and thank you for asking us. By continuity, we just mean patients and doctors having a chance to see each other repeatedly. And it's a very old feature of general practice. It goes back hundreds of years. What is new is that there's been a mass of research which suddenly reveals that it's very important indeed. This isn't as well known as it might be, and we hope that it'll get spread now that we know about it. For example, if patients get continuity with GPs, they are much more satisfied.
Yep.
And in all services where dealing with people or clients, that's the very important outcome. And it's quite clear that if patients see the same doctor, they're much happier. So that's the first one. And there's a slide, I think, that will show the list of the 9. We can just run through them very quickly. But the second one is that patients and doctors, once they know each other, patients follow advice much more.
Yep.
And that's good for them. It's also, with most advice, is useful. And that spills off not just to what the GP may say, but even to what the GP prescribes. So that if you take the commonest of all the prescriptions in British general practice, which are statins, there's a 5% difference. So that patients who have continuity are 5% more likely to keep taking the tablets and not just drop them off. So that's that translates into thousands of heart attacks a year. So it makes a big difference. And it's more than that, even for evidence-based preventive medicine, things like immunisations and cancer screening for women. And we've got a problem in Britain because at the moment we have a measles epidemic in Britain with 72 deaths and 1,000 cases. Very sad, and yet families that have good continuity are much more likely to have immunisations, and women who have good relationships with their GPs are much more likely to accept breast screening and cancer screening of the cervix. So all of that goes with this. So those are pretty big gains. And then the really overriding issue, the theory of it all, is that the relationship develops, that patients and doctors get to know each other, they get onto the same wavelength, they start to understand each other. And the interesting research shows that the GPs then become more sensitive to the particular patient. Yeah. So they read the patient's anxieties better, they tailor their advice more to that particular patient. So that is a big win for the patient. It's also more satisfying for the GPs to do that. So the really big one here is that in fact GPs are better, provide better care with patients they know. And the quality of care is measurably better. And so that's a big win for patients, it's a big win for doctors, it's a big win for the health service. So all of that is inside the practice, but really interestingly, there are several very important outcomes that are outside the practice altogether. For example, patients who get continuity of GP care are much less likely to go to A&E. Significantly less likely to have to go to A&E. And the really big one is that they are significantly less likely, as Hannah said at her introduction, to end up in hospital for a condition that's suitable for GP treatment. And patients hate going into hospital unnecessarily, and it costs the health service £1,850 a time. So it's bad news all round. And continuity is one of the things that has been shown significantly to make a big difference. And then the sort of biggest of all, which I was lucky enough to be involved with my friend Professor Evans, who's speaking later today, we found only last year in the St Leonard's practice that continuity of GP care is associated with lower death rates. So people actually die less. This is a systematic review of all the published literature in the world, and we've been very encouraged by the interest that has led to. And I think that is a kind of summary of all these other things put together. It actually ends up with people dying less. And that's all about doctoring and medicine and patients, but there's a citizen issue. The last one is that there's a citizen issue of we as taxpayers and people living in this society. Continuity of care is associated with much lower costs. Yep. That people are not having a lot of tests repeated, they're not going to A&E at £100 a time, they're not going to hospital at nearly £2,000 a time. And so the whole service runs more smoothly, so that from the policymaker's point of view, continuity of care is really good news.
Yep, so that's very impressive. And I think I read that if you had 10 consultations with a patient and 2 more with that same patient, then it's something like 6% reduction in admissions, I think it was.
Yes, well, the Health Foundation, and we're in a Health Foundation project, they were this important article and they quantified that. So it shows quite quickly, I think.
Yeah.
So that's the good news. It's not an impossibility.
And that was the paper that kicked off this whole programme, didn't it? I think?
Kicked off the Health Foundation programme. In fact, there'd been other research in other parts of the world which had shown the same thing, but I mean, this is what drove the British interest.
Yeah. And I suppose we ought to start with asking what we mean by continuity. That's quite a fundamental question, isn't it?
Yes, well, simply we're taking it as patients and doctors seeing each other repeatedly.
Right, okay, so that's
Face-to-face is what we're talking about, yes.
Yeah. And the Health Foundation programme, of course, is looking at doctors and GPs in particular, but
yes.
we might talk about the wider aspects of that. And what do you think patients think about continuity of care? You mentioned it a little bit, but just to...
Well, patients are pretty clear, actually. For years, they've been saying that they feel more reassured if they've got a doctor they know what to expect, and it's a less daunting prospect. And actually, one of the big complaints at the moment, which is very sad to hear, is the cry, "I don't see the same GP twice."
Yeah.
And that's a patient expression of a very important problem in the health service at the moment.
Yeah, that's it. Now, I've mentioned a bit earlier about it being focused on GPs, but what healthcare staff are we talking about with respect to the programme and continuity?
Well, the Health Foundation specified the GP continuity and the GP relationship. It's very important that GPs work in teams, and we're lucky enough to have nurses working with us, and there are an increasing number of people, as you know. The research evidence is much stronger with doctors, so it seems logical when we're starting in a complex field to start with the GPs, and that's what we're doing, and we're trying to measure continuity of GP care. You can do it for nurses as well. The methods are the same, but you've got to start somewhere.
Yeah, and in fact we focus on GPs because we talked about secondary care, but I think we've homed down on general practitioners for this programme actually.
Yes, and they do provide 350 million face-to-face consultations a year, so it's pretty important.
Yeah, I would go with that. Now, we talked about the evidence base, and I certainly have a face validity. I think how important it is to me, the continuity. But can we just discuss whether the evidence base is sufficient? Because some of this is about associations, some of this is about qualitative studies or anecdotal studies. Do you think there's sufficient evidence out there?
Oh, definitely. It is technically true that many of the studies are associations. That's an epidemiological finding. But there are randomized controlled trials, for example, in midwifery, where only 6 months of midwifery care, continuity of midwifery care, means a woman is 16% less likely to lose her baby. So, I mean, this is big stuff in a very short period of time. And there are a few randomized trials in medicine as well, and I hope there will be more. So I don't think, and when you think there are hundreds of articles all pointing one way, and I think there are about 4 pointing the other way, I don't think it would be sensible not to draw the obvious conclusion. This is very important.
Yeah, so it's a weight of evidence there, the
weight of evidence, the volume of evidence, and also it's international. You're getting the same findings in different countries, different languages, different continents. It's very hard to believe there isn't a biological effect here that runs across.
Yeah. Yeah. And then we've got the modern NHS, so-called, and we're prioritising access. Do you think continuity is a realistic thing that we can really move towards?
Yes, I think there are real tensions. GPs have got their hands full at the moment. We're 5,000 GPs short, and they are being, as you say, pressed into providing access. In fact, we are quite clear that continuity is still perfectly possible, and my colleagues and I from the St Leonard's practice have published an article which shows that 65% of all the consultations for people aged 65 or more, where most of the multimorbidity and the chronic illnesses, 65% all around the year, are with their personal doctor, even though every GP in the practice is part-time. And they're all having holidays, and they're all having study leave and all the rest of meetings and all things you and I know about. So it's perfectly possible. And the whole practice, the average is about 50%. So there should be more than a 50% chance of seeing your personal doctor every time you go. That's possible. We hope that other practices may do better than that.
Mm-hmm. And I think indeed in the programme, we're talking about some practices getting to 70 or 80% continuity as a result of the programme, possibly.
We haven't got those but in the Exeter wing, but we'll look forward to hearing those if there are some.
Yeah, so it is achievable. Then.
It is achievable. Yeah. Well, adequate continuity is achievable. It can't ever be perfect. We're in a very complex system and GPs are very busy. But adequate continuity is achievable, and continuity for the elderly is certainly possible, and we've shown it. Mm-hmm.
Okay. Now, just for a break for a second, and say if you're listening to this, you can put in queries and questions. You've got a chat box on the right side of your screen, so do by all means add to that. And if you've got any questions for Sir Denis Pereira, then please do send them in. And we were talking a little bit about subgroups earlier, and the question might arise as whether everybody needs continuity of care, or whether you feel that there are groups that might need it more than others.
The biggest single issue in all this research over more than 40 years is that the bigger the practice, the worse the continuity. And that was found in the Health Foundation research. And it just is a function of size. When you have more and more patients, more and more doctors, patients just get lost in the system. So the central key is to divide the list in some way, to make it manageable. And there are two main ways of doing that. One of the ways is to have a group of patients and then a group of GPs, and often with nurses or other colleagues. People sometimes call these mini teams or micro teams, and that's a perfectly sensible way to approach it. The other way, which we happen to use, which is the longer history, is personal lists, where we actually have a group of patients, a list of patients, and one particular doctor taking personal responsibility. That is possible. We were in a practice as big as 18,000 last week, where the practice was running on personal lists in a big city. So it's perfectly possible. It's a question really of what the GPs want to do and the management wants to do, but the key thing is you can't have 18,000 patients and patients milling about and expect good continuity. You have to break it down into something that is manageable.
Yeah. And I'm glad you mentioned the sort of variety there, because when you say about personal lists, I'm thinking how difficult it might be to get back to that for our practice. But actually, there's a range of things to
you can do, and micro teams is a perfectly sensible halfway house, if you like, and it's so I think it's each practice to make its own mind up. They are independent organisations, and they need to. It's about knowing how strong the evidence is and then looking at ways you can implement it.
Yeah, and indeed microteams is one of the things that's come out of this programme, and there's been a lot of discussion about what a microteam is.
Yes.
And we've worked from sort of a buddy pair of doctors, and then there might be the doctors with their assistant or with a nurse, and it seems to vary quite a lot, I think.
It varies a lot, and it would be very helpful if the Health Foundation could help, and the college for that matter, help to get some agreement about definition. And of course there is an academic problem, which is that there isn't any research yet which supports. It's at the stage of it's a good idea at the time, and we all hope it works, and it's certainly sensible, but the research is actually not there yet.
Yeah. Okay. And I was thinking about, from the programme itself, have there been questions that have emerged from the programme, other than microteams, that we need to address and look at a bit more?
Well, I think there are a range of doctor benefits which we haven't touched on. For example, GPs get greater satisfaction if they do a good job, and they feel it, and if patients are actually complying and doing what they recommend, it's easier to work. But there are some very subtle ones for GPs as well. I mean, for example, there's research showing that if the care is generally good, patients will forgive a GP who makes a moderate mistake. They won't forgive a terrible mistake because they're human beings, but if it's a moderate mistake and the rest of the care has been good, patients are able to say, well, he or she's okay most of the time and this was a bad day. And in our workshops, we had some really interesting discussions of GPs who have made mistakes and said actually they were able to see a patient they knew very well and say, I am frightfully sorry I got that wrong. And the patient has said, you're usually okay, doctor, can forgive. That can't happen with strangers. So continuity has a huge element of protection for both sides. The patient feels more empowered and the doctor has actually got a measure of protection.
Okay.
So I think these are all quite subtle things that are just coming out.
And as we're talking, I'm just checking on the laptop to see if there's any questions coming in. So do send in any queries or questions you've got, and we'll look at those. And actually, your very comment about being forgiving to your patient, to your doctor, is really helpful. I remember my appraisal was yesterday, and we were talking about exactly that topic, and you know how as a doctor you can make mistakes and not be aware of these things, and then it comes back to you, and you realise actually, really rare diagnosis, but actually working with the patient, they're very forgiving, and you can move on in your relationship.
Well, indeed, and we have examples of GPs who have made significant mistakes, and the patient has stayed, and the relationship has been good thereafter. Right. And as we're facing a situation where there are 75,000 complaints against GPs at the moment, this is an issue for every general practice. So I think anything that makes a difference is worth serious thought.
Yeah, great. Now we've got one question come in here. I'll just read it out for you. It says, how do GPs ensure continuity in the light of increasing specialist work, which happens in general practice? Patients will sometimes be better to see another GP with greater knowledge in one area or another, or indeed another clinician type, such as an AMP or pharmacist.
Well, that's an important topical question. Well, the answer is, again, what the practice wants to provide and whether it actually values its continuity. It's quite interesting. I think GPs for 100 years have seriously undervalued themselves. And the research is quite clear that a GP who really knows his or her patient is better and does a better job. And that's not true to say that the next GP will be just as good. And the idea that any doctor will do is not true. We haven't got the research for that. So I think they should be more confident that if they give the time and try to see patients regularly, it will pay off. As far as other professions are concerned, we haven't yet got the comparative research, and we just don't know if nurses, pharmacists and paramedics or whoever it may be will build the same relationships or get the same effects. We wait to see.
Yeah, I very good challenge you there and say, yes, continuity may be a bigger thing, and we're looking at continuity for the nurse or paramedic, possibly. It's interesting, in my practice, I am one of the leads for the eyes, so I have a slit lamp in my surgery, which is pretty uncommon. So there is a little bit of balance, I suspect.
Absolutely. And some doctors have special interests or are called GPs with a special interest. That's fine. The beauty of general practice is it's so flexible that the GPs have a huge amount of scope. It's a great privilege. They can actually run the practice as they want to. So you can do your specialist interest, but it needn't detract from the continuity you or others provide if you want to provide it.
Well, certainly we try and do that. We try and get our usual doctor to have the oversee, and then the other doctors might come in and out as needed, or other members of the team. So that's really good.
Of course, the NHS contract actually requires every NHS GP to give every patient a named and accountable GP.
Yep.
So it's an interesting question what accountability means there, but there is actually under the mainline contract a responsibility for one GP to be accountable for every patient.
That's great. So thank you very much indeed for your contributions. It's really helpful, and to know that body of evidence is there is very encouraging. And I'm so glad that exists, because it goes with what I think is the case.
And the references are on the slide if your people want.
So thank you very much indeed, Sir Denis. Much appreciated.